Welcome to GW Hospital Healthcast. I'm Dr. Mike Smith, and today's topic is HPV and throat cancer. My guest is Dr. Poonen Thakur. Dr. Thakur is an assistant professor of surgery at George Washington University School of Medicine and Health Sciences and a member of the medical staff at the George Washington University Hospital. Dr. Thakur, welcome to the show.
Thanks for having me.
Well, why don't we just start off first? What is HPV?
So HPV is the human papillomavirus. Now, this virus is quite prevalent. There's different types of this virus. There's type 6, 11, 16, and 18. Now, the higher number, 16 or 18, are the ones that cause cervical cancer, and that we know. But they can also cause cancer in the base of the tongue or the tonsil. That's the oropharynx. Why it's interesting is because in the last 25 years or so, we've seen a decline in some of the other head and neck cancers, but oropharyngeal cancer rates are rising, and that's because of this virus. So we're seeing this type of cancer in younger, healthier patients who've never had a history of smoking and drinking, and so they're different from our typical head and neck cancer patients that we think about traditionally.
So let's back. So HPV is a virus, right? And how is it usually transmitted?
So it can be transmitted sexually or by mucosal contact. So theoretically, kissing, oral sex. It's not really known how the transformation happens between just carrying HPV and actually progressing to the cancer. That's something we don't quite know exactly why some patients progress to cancers and others are just carriers. But it is prevalent in more than 95% of people have, or at some point in their life, have been positive for HPV.
Okay, so it takes some sort of close contact, right, to transmit
Correct.
This virus. And you said something interesting. You said that we're seeing, I guess, especially those strains that are more linked to cancers, we're seeing those strains, those HPV strains increasing in general in the population. Is that true?
Right. I mean, there's different theories for why this is the case. People have changing sexual practices, more sexual partners than, traditionally in the past. So this may be one of the reasons why we're seeing higher numbers of these cancers.
Yeah, and so when we look at the large population of people who have, let's say, like you said, a carrier of HPV, who do those people look like? Are they mostly men, women? What's the age group?
So, the carriers of the HPV, it's not a particular, any age can be carriers. In terms of which of those patients are positive for cancer, usually that age group is 40 years old and above. And right now it's a higher proportion of men, but we're seeing more women with oropharyngeal cancer than we have in the past from smoking and drinking.
Yeah. And so I do think a lot of listeners, Dr. Thakur, probably are familiar with HPV and maybe the cervical cancer part of that, right? I think there's a lot of public service announcements about that, get the pap smears, all of that stuff. But I don't know if a lot of people understand that HPV is also related to cancers of the mouth and the throat. So when you look at all the different cancers that happen through HPV, what percent are occurring in the oral cavity and in the throat?
In general or HPV related?
HPV related.
So in 2016, there were about 500,000 cases in the country of HPV cancer. And it's predicted that by 2020, the rate of HPV related oropharynx cancer is going to be higher than cervical cancer if it keeps going the rate that it is.
So since we're talking about a viral infection, right, and you had mentioned that it's close contacts, most likely sexually transmitted, what are some of the signs and symptoms that we should look for just in case we have HPV infection?
So HPV infection is asymptomatic. HPV infections that are caused by the less virulent strains, and that would be HPV 6 and 11, those will just cause warts. So those are called papillomas. Those can occur in the oral cavity. Having these papillomas or warts in your oral cavity or oropharynx actually does not increase your risk of progressing to cancer. On the other hand, if you have an HPV positive tumor, the signs and symptoms would be the same as a non-HPV positive throat mass. So for HPV positive cancers, we've seen that even very small lesions have a propensity to metastasize to the neck nodes. So the first sign would be a mass in the neck. Now, when an adult has a neck mass that's persistent for 2 weeks, it's highly possible that this is a cancer. And so it should be evaluated first by the primary care physician. And if it persists past 2 weeks, there are recommendations by the American Academy of Otolaryngology and Head and Neck Surgery that the primary care doctor should refer to a specialist, and further imaging and biopsy is certainly warranted. So the most common sign of a newly diagnosed head and neck cancer that's HPV positive is a new neck mass.
Right. So obviously that's a good reason to go see your primary care. You mentioned the papilloma, right? So if somebody has a papilloma, or what you just said was a wart in the oral cavity, should they still go see their doctor to make sure, get that checked up? 100%.
Yep, 100%. If it's a small papilloma and they come and see an otolaryngologist, then most of the time we can excise the lesion in the office, and you can get a biopsy result in a week. When there are tumors in the base of the tongue or the tonsil, they may require a biopsy in the operating room, but small papillomas in the oral cavity are very easy to biopsy. So definitely any new mass or lesion in the oral cavity or in the oropharynx should definitely prompt a visit to your primary care doctor and a specialist thereafter.
Okay. Now, if somebody comes to you with a neck mass or a throat mass, right, how do you know if it's HPV related or not? What's the workup for that?
So the first step, would be imaging. If we can also do ultrasound in our office and do ultrasound-guided needle biopsies, and those are usually small-gauge needles, just about the size of the needle that you get your blood drawn with. Once we do the needle biopsy, we can send it to our pathologist, who can test it for the HPV virus with certain immunostains, and that stain is called P16.
So just to kind of back, so there's a specific stain that you can do in the laboratory that will tell you if this is HPV related or not.
Correct.
Now, once you're ready for treatment, so you have a person come in, there's a neck mass, you've done the workup, it's HPV related. Tell us about the treatment, both from a surgical or from the cancer perspective, and then also from the HPV perspective.
So from the HPV perspective, it doesn't really change the management. It does change the prognosis. So for early stage oropharynx cancers in the tonsil or the base of the tongue, there's two options. One is non-surgical and the other is surgical. One option, if the patient does not want surgery, would be chemo and radiation, and that's given concurrently for about 6 weeks. Depending on the stage of the disease will depend whether they need just radiation or chemo and radiation. The other option is surgery, and for early stage cancers of the base of tongue and the tonsil, there is the advent of the transoral robotic surgery. So there's two systems that are used here at GW. One is the Da Vinci robotic system, and the other is the MedRobotics Flex system, and both are approved for early stage tumors of the base of the tongue or oropharynx. The reason these new robotic surgeries are helpful is because in the past, in order to get access to the base of the tongue, we would have to split the mandible, and that could be quite morbid for the patient, as you can imagine. With access to these robotic surgical techniques, we can get access in those hard-to-reach areas, and patients are out of the hospital in about 48 hours.
Wow, nice.
And drinking, eating and drinking just as they were, swallowing is fine, and their speech is fine, and
Dr. Thacker, let me ask you a question about those robots, right? Because I think, and I want you to explain this and use this to educate, the audience about robotic surgery. Because when you say robotic or robot, people have certain things in their minds, right? What exactly is,
yes.
and I want you to clear that up for us, right? Tell us exactly what robotic surgery is.
Okay. So, one question that I get asked all the time when I mention robotic surgery is, will you be there in the operating room? And 100% your surgeon will be in the operating room. What the robotic machinery does for us in the operating room is it's set up so that the instruments are in correct position, and then the surgeon sits at a console. So in the console, we have complete control of whatever movement those instruments have in the throat. The arms of the instrument are obviously smaller than any of the instruments by hand that we would use, and the magnification is much more than what we can get with our eye. So that's the benefit. One is the access, two is the magnification, and it's also, we see in 3D with the robot. So that's actually very helpful when performing these operations.
Right. And so, but I think the important point, right, and this is for everybody to understand, the surgeon is still doing the surgery. You're simply controlling.
It's just, right.
Yeah,
correct.
You're controlling these arms that are just allowing you to get access to tough spots. The magnification is better. It makes the surgery better. And as you said, the outcomes are a lot better. And I thank you for clearing that up for us. So when somebody goes through this kind of treatment, though, for a oral or throat, cancer that is HPV related, you had mentioned that prognosis is different than somebody who does not have HPV and has a throat cancer. Tell us a little bit about the difference in outcome.
Sure. So oropharyngeal cancers caused by the human papillomavirus have a definite favorable survival. This was first found in a landmark study that was in the New England Journal of Medicine in 2010, which demonstrated that patients who had HPV-positive tumors had significantly better overall survival. And when you looked at their 3-year overall survival, and this was back in 2010, it was 82.4% versus 57%. So much, much better survival curves. And so patients do better, whether they go with traditional non-surgical routes of chemo or chemoradiation or surgery. Now, these studies regarding the survival benefits and treatment options with TORS are just now being published, and there's a large clinical trial that was just closed in July 2017, which is going to answer some questions that have come up, and namely, patients. We know that HPV patients have overall survival, which is better. So, can we de-escalate their therapy? Meaning, in the past, someone who had a significantly sized tumor that was stage 3 would need multiple modes of treatment, surgery and radiation or chemo and radiation. The question is now, can we de-escalate their therapy so we can do surgery alone, surgery with a lower dose of radiation, surgery with standard dose radiation, and then surgery with chemoradiation? Right. They're going to look at all these 4 groups and see if there's any benefit to decreasing the treatment they receive, because long-term higher doses of radiation and chemo can have an effect on swallowing and fibrosis, and that's the next step, and we should get that information in the next couple of years, hopefully.
Yeah, that's very exciting. So, Dr. Thacker, I always just kind of like to end in summary. What would you like people to know about HPV-related throat cancers?
So, as far as we know, the cancer is not contagious. So, it shouldn't be a reason to frighten people to change any habits that they have, because there's no evidence that kissing causes cancer. I think that's really important. We don't know why certain patients progress to cancer and others don't. There's more than just the virus. It's genetics and other things that we don't understand. Number two, any adult with a new neck mass, it's important not to just assume that it's infectious or it's going to go away. Just go and see a physician, whether it's your primary care doc or an ENT, preferably, who can evaluate this right away. Because, even 40 years ago, studies show that there was about a 5 to 6 month delay between a new neck mass and getting their diagnosis. Even today, studies show that there's still a 3 to 6 month lag. So,
wow, yeah.
Despite better imaging with MRI, CAT scan, PET scan, we're still not identifying patients right away. And that's something we see all the time, just delayed diagnosis or patients being treated with multiple courses of antibiotics for a neck mass because it's presumed to be infectious. And in fact, it's not. It's cancer. That's why it's not going away with antibiotics.
Right.
And thirdly, it's important to know if you have this new diagnosis that there are options for your treatment, and you should definitely go to a center which explains all these options to you to make sure that if you're getting the treatment that makes most sense for you. If you're young and healthy and can tolerate surgery and it's an early stage cancer, you may do fine with just having robotic surgery and perhaps some low dose radiation. But you have to go to centers that are treating these tumors so that an informed decision can be made with a multidisciplinary team to treat your cancer in a way that makes sense for you, and that's standard of care.
Right. So go to the specialist, right, and go quickly. Don't waste time. Dr. Thackers, thank you so much for the work that you are doing at George Washington University and our George Washington Hospital. And also, thank you so much for coming on the show today. You're listening to GW Hospital Healthcast with the George Washington University Hospital. For more information, you go to gwhospital.com. That's gwhospital.com. Physicians are independent practitioners who are not employees or agents of the George Washington University Hospital. The hospital shall not be liable for actions or treatments provided by physicians. Individual results may vary. There are risks associated with any surgical procedure. Speak with your physician about these risks to find out if robotic surgery is right for you. This is Dr. Mike Smith. Thanks for listening.